So for anybody who doesn't know me, I'm Karen Slye and I'm a clinical specialist dietitian in the Mater Hospital. So I'm going to discuss the journey of one of my patients who started off in ICU. And the reason I picked a picture here of a lady hiking is because that's what she likes to do. And she has recently got back to hiking, but definitely not at the level that she was before, but she has gotten to do it a little bit. So she's at home now. So just a bit of patient introduction. This is a 58-year-old female who presented to A&E with abdo pain and vomiting. Her past medical history included arthritis and hypothyroidism, and she hadn't had any previous surgeries. Her social history is that she was working in the hospital as a nurse. She lives alone and she loves hiking and camping. She weighed 60 kilos with a BMI of 22 with no signs of muscle wasting on presentation. So she presented at about 17 minutes past 7. Actually, she was working at the time that she developed the pain, so she went down to A&E, and by 4 minutes past 8, she had a lactate result of 3.2 and severe abdo pain. She had a CT of 5 to 9, and the only reason I put the snippet of the CT result here is because it actually was extremely accurate in relation to what they found, what was reported in the CT. So sadly on CT here, it shows that she had advanced ischemia of almost all of her small bowel. So she was actually brought to theatre at 11 o'clock. So quite a quick turnaround for the lady to present at 17 minutes past 7 and to be in theatre by 11. And yes, so what they found in theatre was that she had a small bowel volvulus. So her bowel had twisted on its mesentery, causing it to be obstructed, and sadly it was ischemic. So nearly her entire small bowel was ischemic. They did warm the bowel up to see if it would have any impact on, how much they could salvage. But sadly, they could only salvage 25 centimetres of small bowel from the DJ flexure to her stoma, and then distally she does have 20 centimetres left of small bowel to her ileocecal valve and all of her colon, but that's not in continuity. So as the dietitian, I guess we only have access at this time to the 25 centimetres of small bowel from her DJ flexure. I think it's important to mention the bowel length, because when she was in ICU, there were definitely comments by some people about how she had 45 centimetres of small bowel left, and okay, she does, but we don't have access to all of that. Clinically, that's not necessarily that significant, because the difference between the management of somebody in this case with 45 versus 25 isn't really any different really, but it could be in a different case with the bowels that's left that it might have an impact on management. So I guess I'm just highlighting here how important it is, if you are the dietitian looking after these patients, that you know for definite what bowel your patient has, what access you have to feed or not to feed, or what their needs are. It's the more op notes that you read, the better you get at interpreting them. And if there's any questions or doubts, then ask the person who was in the surgery, ask them to clarify. They love drawing some little pictures sometimes as to what the patient has left too. So this is just an aside in relation to distal feeding. We haven't decided to distal feed this lady. The reason being, I guess, in relation to distal feeding, some people recommend doing it if you can get them off and they're off the PN entirely. So if what you can put down the distal limb can match or be more than what comes out the upper limb. One of the main reasons that I guess we haven't or we wouldn't in this case is we're waiting for them to get an opinion from a specialist centre. So I guess the team that were managing the patient didn't really want to do anything at all really until they get that opinion. So from a PN perspective, if we look at some recommendations in the ICU setting, so the ESPN 2023 guideline on clinical nutrition and intensive care, in relation with, I guess, regards to PN, they make some comments like within 3 to 7 days if enteral nutrition is contraindicated, early progressive parenteral nutrition if severely malnourished and enteral nutrition is contraindicated, which isn't the case for our patient, she wasn't severely malnourished, or supplemental PN 4 to 7 days if enteral nutrition is not tolerated. There's also recommendations now to gradually build on calories from a small, to less than 15 calories per kilo at the start and gradually build, and the same with protein. For us, I guess, she presented on a Monday. On Tuesday morning, she would have been picked up with dietetic screening, as straight away we have a patient here with 25 centimetres of bowel. Did we PN her that evening? Yes, we did. We had a patient in front of us that we knew we weren't going to be using another route, so we did start her on PN on day 2. Conservatively, we gave her just under 15 calories per kilo, and then progressively moved her from 15 to 22 to 28. But we did make the decision to start on day 2. If you look at some requirements when patients move off the ICU setting, there's quite a few available. There's the ESPN guidelines back on surgery back from 2009, which have some recommendations of 25 calories per kilo of ideal body weight, or up to 30 calories per kilo in severe stress. The acute intestinal failure recommendations highlight that indirect calorimetry is the best option, and we do have indirect calorimetry in our Matter ICU, but this lady actually had a very smooth ICU course and was extubated too quickly before that could be done. So they also recommend 25 to 35 calories per kilo and up to 1.5 grams of protein per kilogram. The chronic intestinal failure guideline from 2021, and I guess you might be thinking, why am I mentioning chronic? I guess from the get-go we knew that this lady was going to be chronic, so just to mention them, that they say about 20 to 35 calories per kilo and 0.8 to 1.4 grams, and then Bapen have some protein recommendations that work out at about 1 to 1.85 grams of protein. So there's quite a large range available, and for our 60 kilo lady, that's a range of about 1,200 calories all the way up to 2,148 grams of protein, up to 113 grams of protein. Just to mention glucose oxidation rate, glucose is the main source of energy used in PN, and excess can lead to hyperglycemia, fatty liver, impaired respiratory function, and this lady, I guess, was initially in ICU. So, but in reality, the calculations are quite broad. So for from 4 to 7 milligrams, which works out for a 60 kilo person at 346 to 605 grams of glucose for our patient, which we didn't exceed. From a lipid perspective, if we look at recommendations, so there's the minimum recommendation of at least 1 gram per kilo per week intravenous lipid, if fully dependent on PN. I would class our patient with 25 centimeters of small bowel available to be fully dependent. So we are giving her at least 1 gram per kilo per week. Other recommendations include, in the chronic scenario, not exceeding 1 gram per kilogram per day of soybean-based lipid emulsion. I don't think many people are actually on purely soybean-based lipid emulsions on their PN nowadays, really, and our patients aren't. But we do, even though the recommendation is in relation to soybean, we do also aim to not exceed 1 gram per kilogram per day of lipid in total. It's also important to consider the introduction of lipid-free plan, but not necessarily. We don't tend to do this very early. That we would make sure that the patient is definitely not septic, not on inotropes, not really sick, before we typically do that. So for our lady, our plan would be to give her no more than 60 grams of lipid per day, but also a minimum of 60 grams of lipid per week. And although these are in the chronic intestinal failure recommendations, we would take this from the get-go. The acute recommendations do go as far as saying that you can give up to 1.5 grams of lipid per kilo, but we typically don't give patients anywhere more than 1 gram per kilo of fat. So losses with somebody with with 25 centimeters of small bowel, which I guess from a Bapen perspective would be classed as ultra short, and for an adult, it's important to have a basic knowledge of losses. This table is in the INGI guide, and it's very much a rough guide and not not an exact science, but if we have a look at the jejunostomy losses, it suggests that about 140 millimoles of sodium is lost in about a litre of jejunal fluid. Personally, I think it's more important, not more important, might be a bit I like to look more so at what the patient is receiving and how stable they are and what they're receiving as well. So typically we don't move our patients onto patient-specific bags until we get a good knowledge as to what their losses are, what they're needing. In the ICU setting, it's very easy to replace electrolytes and fluids. They're extremely good at it in the ICU setting. They can also give it in very small volumes. So I would tend to get a good grasp as to how a patient is and how much they need before I switch them to a patient-specific bag. But one thing that I definitely would have a strong look at is exactly what electrolytes they have been receiving in additional IV fluids. So this is just a chart as to what's in typical bags that are used in hospitals. So electrolyte needs. This table is in the ESPEN 2023 chronic intestinal failure guideline, and it is acknowledged within the guideline that it's just based on clinical experience, so it's not a strong evidence base, but the suggestion in that is that electrolyte needs for our PN population is about 1 to 1.5 millimoles of sodium per kilogram, the same with potassium. So if we look at my 60 kilo patient, that's about 60 to 90 millimoles of sodium, but she is at this stage by day 6 in ICU was losing about 2 litres of outer stoma, and so if we look at the 140 millimoles of sodium per litre of jejunal juice, she was probably losing about 280 millimoles. To compare that to what she's currently getting, she's currently getting about 90 to 120 millimoles less than this. She's getting 250 millimoles in her bag and does seem to be okay on that amount. From a potassium perspective, it says 60 to 90 millimoles, so that's 1 to 1.5 millimoles per kilo. And it doesn't acknowledge that jejunal juice in the INGI book has potassium losses, but the ESPEN guideline does highlight that for very short bowel patients, you typically need in excess of 100 millimoles, and our patient is currently getting 125. For phosphate, there's the recommendation is about 18 to 30, and she is getting 30, and 6 to 9 of magnesium, she's actually on 20, and 6 to 9 of calcium, and she's currently getting 6. If we look at her ICU progress, she was actually extubated by day 2. She was on no ionotropic support. She was on room air by day 3, and she had mobilised a lap of ICU on day 3. She actually had a really smooth course, despite the fact that she had major surgery. Comments on day 6 did include that the patient was quite upset, and obviously this is a major life change that has just happened to her, and as a quite high up nurse, she would have had that understanding there as well. She was listed from discharge from ICU on day 8, but she actually stayed until day 10 when the bed was available. And looking back at her stay, I think part of this might have been that they thought she would become more sick than she actually did. And also there might have been an element of the fact that she was a staff member. So thinking cap, what types of things was I thinking about when I had a patient like this and this lady in ICU? So don't overfeed, I guess. At this moment in time, we were thinking that she might be a lifelong PN dependency. So it's not that we want to underfeed our patients, but we also definitely don't want to overfeed. Early oral restrictions. So in relation to oral intake, somebody with 25 centimetres of small bowel is clearly going to need quite significant restrictions. From my experience, it's better to have restrictions in place from the start so that you're not having to rein in a patient significantly. So that involves everybody being on the same page in relation to what the recommendations are. And initially, because of the surgery that she had, to be honest, the surgeons were probably a little bit slow to let her have anything orally at the start. In any way, but it's just really important that we play a role in educating other people and the pantry staff, and that everybody speaking to the patient is given the same message. An early switch to lipid free if the patient isn't septic and is quite well, and this was done just after she left ICU. Cycle feeding when appropriate, so again we would have got her onto 12 hours of her PN. Bateman recommend doing this after about 2 weeks on PN, so that's their recommendation. Have we done that quicker? Yes, we have. And being honest, I think she kind of flew through her journey, really. She was walking around the ward, and she was very well, so we did get her onto 12 hours as soon as she hit the ward. And we did it in a 24 hours, then to 18 hours, and then to 12 hours, because she had no risk factors for hyperglycemia. High output stoma protocol. So we have this nice 5-page document in the Mater Hospital, and to be honest, I don't know how we coped before we had it. I think it's a very good document, because at the end of the day, especially when somebody moves to ward level, it's junior doctors that are making the daily drug changes, and not everybody has managed a patient with 25 centimetres of small bowel left. this document gives us, I guess, the power to be able to show when somebody, for example, is on a loperamide dose that might need an adjustment. And I guess as we don't have a Haidee, like who's going to talk next, the pharmacist, a specialist one in the Manor Hospital, we do sometimes as the dietitian play a role in encouraging changes and highlighting the high output stoma document. It does give, it does make it easier for the junior doctors to make changes because they have something written down that supports the advice that we are also trying to encourage. So if you don't have one, I'd highly recommend getting one. Patient-specific PN bags, as I mentioned earlier, this is something that we do when I have a good grasp as to what the patient needs. And sometimes patients' stomas do kick out quite early after surgery, others take a bit longer. Hers would have been classed as high output from about day 6. But then there's obviously then going to be the changes again when the oral intake is introduced. And it's, I'd say imagine in Haidee's Hospital in Southampton, you can get access to, probably the same day to your bags, but there's a slight delay in when you're getting your bags. If it's 2 days later, I think it's good to have a good grasp that you're confident that when that bag arrives, that is exactly what the patient's needs. So she moved, I think it was day 18 that she moved on to patient-specific bags. Bowel transplant versus rejoin. It's a very interesting debate in relation to this lady. Technically, if she had all of her bowel rejoined, she'd have 45 centimetres of small bowel or maybe a little bit less, and all of her colon. If you read up on, I guess, PN dependency, typically they suggest that the cutoff is about 50 centimetres of small bowel if you have all your colon, but this, she'd be significantly less dependent on PN than she is now. The other option that has been brought to her and she has been referred for consideration is the option of a bowel transplant. I don't know whether they'd even consider her as a bowel transplant, but they're the two options that are on the table for this patient at the moment. Line access. So I guess, she, even though at the stage where they're in ICU, somebody with 25 centimetres of small bowel, you already know that they're going to need long-term access. So I guess we would play a part in encouraging the team to refer the patient for the correct line insertion when they are moving away from having their CVC. HSE funding. I guess from a funding perspective in Ireland, there's the discharge documentation in relation to somebody leaving. That's one element, but the HSE funding part doesn't have to mean that your patient is actually medically fit for discharge. You might not know what bag the patient's going to leave on, but as soon as it was very clear that the patient was going to survive this event and was going to need home PN, we would have put a HSE funding application in. There's an MDT in ICU in the Manor Hospital. It's a long stay meeting, so she was discussed on day 8 at that, and at that there was a comment saying would benefit from psychological referral due to likely lifelong PN dependency. So she was referred to the ICU psychologist. A lot of intestinal failure teams in other countries would have psychologists on their team. We don't have that, but we do have access to hospital psychological services, so they're not necessarily intestinal failure, experts, but she has had access to psychological referral. Educating others, as I mentioned earlier, in relation to the food side of things, it's important to make sure everybody that's involved in the care is fully aware of the likely course for this patient. For example, the junior doctors on the colorectal team all understand that she's going to need PN long term, and that everybody is on board. So step down to the ward. Everybody knows that from an ICU to moving to the ward setting is classed as a high risk time period for patients, because they're moving from a part of the hospital where they are monitored extremely closely to where they are going to be less closely monitored. So as the dietitian, you can play a role in ensuring that as they move, and I guess I was lucky with having ICU experience that I actually took this, seeing this patient in ICU before she left, so I was able to have that continuity when she moved to the ward, so that everybody understands their fluid restriction. PN versus total fluid needs. At that stage, she was a non-patient specific bag, so her PN wasn't meeting all of her needs, but it's important then that the ward doctors understand that they need to take on the role now of giving the extra fluid fluid and any extra electrolytes that are needed. Is there access to ice on your ward? You know, with fluid restrictions, ice is something that patients can find quite pleasant. Electrolytes, have they been receiving lots of extra electrolytes in ICU? Is it now feasible for that patient to receive that same amount of extra electrolytes in a ward setting where the volume is obviously different? With losses in this case, it's probably not a major issue, but as you know, that's when I would be thinking of moving this patient to patient-specific bags. Dietary needs, that the pantry staff know what she's allowed to have. She's already on cyclical feeding. I'm moving to lipid-free bags, lipid and lipid-free bags. An awareness of rebound hypoglycemia. I say awareness because I think it's not something that happens. The majority of our patients don't experience it. That's obviously where there's maybe an excess of endogenous insulin when your PN stops, and some people have a drop after the PN stops, so after the 12 hours. This lady didn't experience that. She needed a new line, and yeah, so that everybody's familiar with the high output stoma protocol. Questions to ask yourself: is PN feasible at home? So this lady was an extremely experienced nurse, so and also extremely well at this stage, despite the fact that she had the bowel surgery that she had. So she was, I guess, identified as somebody that would have been able to administer her own PN at home. Although interestingly, I thought that she would have liked less training from TCP nurses when she was, but she didn't. She wanted all the training that anybody else received. Is she medically stable? She was actually medically stable quite quick from a medical management, but at the end of the day, as oral intake is increased or introduced, there are going to be changes with the stoma, so that's when you I guess need to manage their PN needs and make the adjustments as required. What are the social circumstances? This lady lived on her own, so it can be a big thing when you're going home in this new situation. So there was nobody else that was going to be trained in this situation, just the patient herself. But she did have a good family network and a good network of friends in the hiking community that came to visit her quite a lot. Do they have a medical card? You don't need a medical card to go home on home PN in Ireland, but our standard practice for a patient like this is to get the social worker involved to get an emergency medical card, because they all meet the criteria in this scenario at the start. So I feel like it can be a nice security blanket for these patients when they leave, that they have that medical card in place. So we do refer to social work to get access to a medical card. Oral intake. So there are psychological and physiological benefits of oral intake. Quality of life, the social interactions of being able to meet a friend. It can decrease biliary sludge. For longer bowel length patients, it can promote intestinal adaptation and can result in reductions in home PN. Oral intake in this scenario is not going to reduce their PN need. If anything, it's going to increase her fluid needs because of her losses, but it's definitely something that from a quality of life that you need to have that liaison with the patient and how much they can have and what's going to work and what can be done safely. And as I mentioned before, there's benefits of early oral restriction and then introduction rather than starting off with a large amount. We don't have many patients that would be classed as ultra short cut. So at the time that this lady was here, I actually reached out to Belfast, who would have a more patients than we would, and they shared what they would normally allow their patients when they're in this ultra short scenario post-op, and it's actually quite restrictive, understandably, I guess, but it's mainly carbs. So you can, I don't know if you can read that, but it's like a slice. They're only allowed one to 3 items a day at the start. So, and an item would be classed as a slice of bread, a pancake, a scone, a fairy cake, 2 rich tea biscuits, 2 cream crackers. So that's what she was given that at the start. She is nowhere near that now. Who's going to stay on that forever? Nobody. She's currently, and just to give a little bit of background from a food perspective, she'd be somebody that you might class as previously a foodie, very healthy diet, very fresh home cooked prepared meals. So her diet was in no way anything, probably never included a lot of these items. She's at the stage now where she is eating very small quantities, but very small quantities of the food that she wants to eat. So I'm not sure if you can see this very well, but this is, I just tried to throw up, I guess, some of her progression, parental nutrition progression, and I'll just highlight a few things. So if you look down here, on day 1 of PN, she got 51% of a bag. And it wasn't until day 19 when she was on a patient-specific bag where she received 100% of a bag. So just a reminder that the recommendation is that our patients receive their micronutrient needs from day 1. So she would have been receiving additional, we use Aditrace, so Cernova and Aditrace M, and from day 1 she would have been receiving additional Aditrace and Cernova to her bag. So we use bags that have the Cernova and Aditrace in them already. If you use 3-chamber bags, obviously they're getting them separately, so it's not, they're getting the whole vial, but if you're using part of a bag, it's just something to be on your radar that the patient is then also getting part of their micronutrients. If we look at the volume, so on hospital bags, which is what she was on for the first 2 weeks, you can see that she got 1,560 mils here, but her first patient-specific bag that she got was a 3-litre bag. And that might sound like, oh, you jumped 1.5 litres, but obviously that decision was made off the fact that she had been receiving a lot of IV fluids alongside her PN. If we look at her electrolytes, so for example, her sodium that she received in her standard hospital bag was about 78 millimoles, but in her first patient-specific bag, we ordered a bag with 250 millimoles in it. And if we look at her potassium recommendation, that moved from her first patient-specific bag was 65 millimoles, but actually she's now receiving 125, and her potassium is quite stable on that. It's also quite well known that very short bowel patients can have a reliance on needing extra zinc, and there is now extra zinc in her bag. This slide is an extremely old image from a book that a man that Haidee knows because he works in Southampton, Mike Shroud, but it's back from 2007 and it still is on the BAPN website, and it's actually a slide that I guess an image that I think is really useful as to what would be a clinical significant change when you are changing somebody like this patient's patient-specific bag. So you have the patient, they're on their patient-specific bag, and they're having regular blood monitoring, and you feel like you need to make a change. What amount of change are you making, adjusting a bag? So we look at sodium, and for example, it suggests multiples of 40 millimoles. So if you have a patient and you think they need more sodium and they're on a patient-specific bag, upping that by 10 millimoles, 20 millimoles, it's just not going to be clinically significant. So I think this table is still something that I would highlight if I was training other dietitians to have an awareness of, because I think it's a really useful slide. In relation to blood monitoring, so we have a system in the hospital where we have set blood lists. So if for example, this is what's currently on our micronutrient list. It says 3 months. Typically, to be honest, we're probably getting our patients' micronutrient bloods done every 6 months rather than 3 months. But this is what's currently on our list. And I know some of those things aren't necessarily micronutrients, but they're things that we would check less frequently, so they're on the list too. It's quite a useful thing to have, because I just click on 3 months and everything underneath, if I think it's relevant, is tested. In relation to blood monitoring, it's important to know what the plan will be for your patient as they move away from being in hospital and go home. So we currently have 12 home PM patients, and 10 of them have their bloods done in the Mater Hospital, so they're dropped to the Mater Hospital. So that means that there are 10 patients that I've supplied their blood forms, their blood bottles, when they're discharged. And it's always the thing that I do the last day before they leave. I keep saying to myself that I must get that organised further in advance, but the last day, it's always when I'm handing them their big pile of blood bottles and blood forms and patient stickers to bring home. But for the 2 patients, for example, that we have, and I'm sure other people have them as well, where the patient doesn't live locally and is having their bloods elsewhere, it's important to know how are they going to get their bloods done. Some of our patients live more than 200 kilometres away from the hospital. Their bloods aren't coming to the Mater Hospital at all. And if you're not providing them with the blood bottles and the blood cards, how are they getting their bloods done? It's just something that is important to organise before discharge. We had a patient recently who was going to be going to a different hospital. I contacted the hospital to ask what blood bottles they use. Is it something that, are they the same as ours? And they made me call out all the numbers and all the rest of the blood bottles that we used, told me that they were fine, and then the first day that their bloods was arrived at the hospital, they were rejected. So, which is quite disappointing, but it is something that you need to know if your patients' bloods aren't going to be monitored in your own hospital. Micronutrient and trace elements, just a little bit here. Obviously, we're assessing for deficiency or toxicity, and you want your CRP to be normal, or at least less than 20, because a lot of these are impacted by the acute phase response. Especially zinc is one of the ones that's well known, will come back low, even if it's not necessarily low if your CRP is high. In relation to micronutrient advice and guidelines, the most recent Espen micronutrient guideline is quite a useful resource to use if you have somebody with micronutrient deficiencies. There's also a nice website in Scotland, the Trace Element website, that I think is useful, more so maybe for a little snippet. It's quite short and it has good kind of scientific results from studies on the impact on CRP. So I think that's also a good resource to be familiar with. For short bowel patients, there's likely an additional need for zinc and selenium. Actually, interestingly, this lady hasn't had any additional selenium needs, but she is on extra zinc. Consider clearance. So it's, I guess, quite common for somebody with ultra short bowel, to have issues with their liver function, and this lady's liver parameters have increased over the last few months as that she's been on PN. And that would then make you to start thinking of an accumulation of things like manganese or copper. So they're important to monitor. She doesn't have renal failure, but just to mention that in the ICU setting, if you do have a patient that's on continuous dialysis, that they, that you're on top of what additional micronutrients they might need, because they're getting too much clearance in their dialysis. And obviously, I think we all know about the magnesium and vitamin D. Now she's meeting all of her magnesium needs in her bag, and her vitamin D is normal. But just to mention, I guess, that we have had quite a lot of success with oral vitamin D with our patients, even in the very short bowel patients. So I think sometimes people think that intestinal failure patients need everything IV and things, but sometimes they don't. So medically fit for discharge. Who's medically fit for discharge? What do? You need to have your bag production, so you need to get all your paperwork to your supplier, all the equipment delivered. The nurse training date tends to be what dictates when somebody leaves. And it's one of the best parts of my job is when I get that date from the nurses and I can go to the patient and say, you can go home on this date. And that is something that I get to do. And I got to do it this week for a lady who is going home next week, and she was delighted because we had quite a quick date for an Irish setting. So it's one of the nicest parts of our job. Let everyone know the date. It's one of the biggest things in relation to MDT. You've been told the date. Does the date suit everybody that's involved? For somebody that, like this lady, there's not necessarily that many teams involved in the discharge, but if you have, for example, like an oncology patient, there's more likely other teams. For example, the palliative care team. In our hospital, the palliative care team really don't like weekend discharges, because the palliative care in the community will not take patients on at the weekend, so they don't like that. So it's just making sure everybody's on board with the discharge date. How often are you going to do the bloods? The blood day, so not as important for this lady, but for example, if any of our patients are on chemotherapy, they get their bloods done the day before their chemotherapy, so that the bloods that we use to monitor them from an intestinal failure perspective are also the bloods that they're using for their chemotherapy monitoring. So there's only one blood that they check that we don't normally check, but it's just the case that now we have that included on our blood forms for those patients. How will you get results? I've mentioned that before. Sometimes the bloods aren't necessarily going to your hospital, so you need to have a system in place to get access. Nights off PN. So most of our patients, if they have nights off, this lady sadly is too dependent on fluids, so she doesn't have any nights off at this moment in time. But for some of our other patients, their nights off go around social events. Like I have a lady that plays bingo. Bingo's on a Wednesday, so their nights off on a Wednesday. most of our patients know though that there is flexibility there with their nights off. So although she usually has it on, if she's off 2 nights, she usually has it off on a Wednesday and a Sunday. But if there's something important on the Saturday, that they have that awareness as to what the rules are, that they can switch their dates to suit the social events that are in their life. Again, the blood forms, blood balls, patient stickers, discharge paperwork, and the follow-up plan. And that's it. There's some references, and if anybody has any questions.